When we talk about diagnosing and managing arrhythmias, most of the time we think about ECGs, Holter monitors, stress tests, or even implantable devices. But sometimes those tools aren't enough. That's where an electrophysiology study, or EPS, comes in. An EPS is an invasive procedure that gives us a front row seat to the heart's electrical system. We use it when a patient has had a cardiac arrest from an unexplained arrhythmia, or when symptoms strongly suggest an arrhythmia we just can't catch on surface ECGs or Holters. It's also used to test how well antiarrhythmic medications or implanted devices are working. And in many cases, the EPS allows us to go beyond diagnosis and actually treat the arrhythmia with ablation. The procedure is done in a specially equipped cardiac catheterization lab by an electrophysiologist with a whole team assisting. The patient is usually conscious but lightly sedated. We insert catheters through the groin, neck, or antecubital vein and position electrodes inside the heart at key spots: the right atrium near the sinus node, the coronary sinus, the tricuspid valve area, and the right ventricular apex. The exact number and location depend on what type of study is needed. These electrodes record electrical activity directly from inside the heart, giving us an intracardiogram. But EPS is more than just observation. Those electrodes also let the electrophysiologist introduce a pacing stimulus. This is called programmed stimulation. By pacing an area of the heart faster than its normal automatic rate, the pacemaker function of the electrodes temporarily takes control, what we call overdrive suppression. Then, when pacing stops suddenly, we see how quickly the sinus node resumes its normal rhythm. If it takes too long, that's evidence of sinus node dysfunction. One of the key goals of EPS is to see if we can actually provoke the arrhythmia. The electrophysiologist will deliver one or more premature impulses to different areas, trying to trigger a re-entry circuit or tachyarrhythmia. If the arrhythmia can be reproduced in the lab, we call that inducible. And if we can induce it, we can then test different treatments, medications, device settings, or ablation to see what works. Later, if a follow-up EPS fails to reproduce the arrhythmia, that's confirmation that the treatment is effective. From the patient's perspective, EPS isn't usually painful, but it can definitely be uncomfortable and tiring. Patients may feel sensations that remind them of when they've had arrhythmia episodes before. That's why patient education is so important. Before the study, the nurse explains what EPS is, how long it may take, usually about 2 hours for diagnostic studies, but up to 6 if ablation is added, and what will be expected of the patient, like lying still and reporting any symptoms right away. Anxiety is common, so a calm, reassuring approach and thorough pre-procedure discussions with the patient and family go a long way. It's also important for patients to understand that arrhythmias may occur during the study. Often they stop on their own. If not, they're treated immediately, sometimes with cardioversion or defibrillation, but always under controlled conditions, very different from the urgency of an emergency setting. After the study, post-procedure care looks a lot like cardiac catheterization care. Activity is restricted to allow the insertion site to heal, vital signs are monitored frequently, and the site is checked for bleeding or hematoma. Because arteries are not always used, vascular complications are actually less common than with traditional catheterizations. In short, EPS is both a diagnostic and therapeutic tool. It helps us identify where and why arrhythmias are happening, test treatments in real time, and in some cases, correct the problem right then and there. For patients, it's a big step toward clarity and hopefully lasting rhythm control.